Usually when we think about a medical diagnosis, there's this expectation of clinical precision.
Right. Yeah.
Like you break your arm, the x-ray shows that jagged white line, and the attending just points and says, there it is, broken.
Exactly. We like things to be visible and neatly categorized.
We do. But then you step into the world of travel medicine and specifically infectious gastrointestinal diseases, and suddenly that precision it completely vanishes.
It absolutely does. I mean, you find yourself relying so heavily on clinical judgment, detailed history taking, and, well, an understanding of probabilistic reasoning.
Yeah, rather than just waiting for a lab result to hand you the definitive answer.
Exactly, which is exactly the kind of ambiguous scenario the MCCQE just loves to test.
Oh, they love it. Welcome to this deep dive. I'm Harvey.
And I'm Donna.
And we are your MCCQE reviewers. Our entire goal here is to help you, the Canadian medical student, feel more comfortable and confident with the exam review process. We'll be breaking down all major concepts covered on the exam.
Yeah, and today's educational deep dive is drawn directly from reliable StatPearls articles covering Section SO7 infectious diseases.
Just a quick reminder before we jump in, though. This discussion is strictly for medical education and exam preparation. It is not medical advice. All clinical decisions you make in the wards should involve a qualified healthcare provider.
Absolutely. So our mission today is travelers' diseases, with a laser focus on travelers' diarrhea.
Right. And by the end of this conversation, the goal is for you to master the exam-relevant definitions, the underlying pathophysiology, the diagnostic heuristics, and those notoriously tricky management traps.
Because there are a lot of traps. I mean, the sources estimate this affects like 40 to 60% of travelers visiting resource-limited destinations.
Which is wild. That makes it the single most common travel-associated condition you'll encounter on the boards.
It really is. So let's establish the baseline diagnostic criteria first, because the exam is actually very strict about what constitutes traveler's diarrhea.
Okay, lay it on us.
So the threshold is either 3 or more loose stools in a 24-hour period, OR, and this is key. A twofold increase from the patient's baseline bowel habits.
Wait, I want to pause on that baseline rule because that feels like a classic vignette trap right there.
Oh, for sure.
Like if a board question describes a patient who typically has, one bowel movement a day, and now they have 2 or 3 while traveling, that technically meets the criteria for traveler's diarrhea, even if it doesn't hit that classic 3 loose stools threshold.
Right. That nuance is highly testable. It's really about a significant departure from their normal physiology.
Got it.
And usually, you'll see this onset about 1 to 2 weeks after arrival in a resource-limited destination.
Though obviously it can happen at any point, right?
Yeah, exactly. But the presentation is almost always precipitous, like sudden onset, accompanied by abdominal cramping, maybe some nausea or a low-grade fever.
Right, and when you're actually performing the physical exam, I remember from clinical skills that the abdomen itself is often quite unremarkable in these self-limiting cases.
Very unremarkable.
You might get some mild, diffuse tenderness to palpation, but nothing like guarding or rigidity. So the provider's real focus is entirely on assessing hydration.
Assessing fluid status is step 1, 2, and 3. You're out there checking skin turgor, you're looking at capillary refill, evaluating the mucous membranes.
Because the primary danger here isn't really the pathogen itself, is it?
No, it's the hypovolemia. In severe cases, the exam stem will give you clues like tachycardia or even hypotension, signaling significant volume depletion.
Okay, so we've established our patient is volume depleted with precipitous diarrhea. To stop it, we need to know what we are fighting. How does the exam expect us to differentiate between the dozens of pathogens that can cause this?
Well, the timeline seems to be the biggest clue they offer. The incubation period is basically your compass here.
Okay.
Bacterial and viral causes typically have an incubation period of anywhere from like 6 to 24 hours.
Fast.
Very fast. But if the vignette describes a patient developing symptoms 1 to 3 weeks after their trip.
Oh, wait, after?
Yeah, after. You pivot away from bacteria and you start thinking about parasites.
Here's where it gets really interesting for test takers then. Why the massive gap in onset time? I mean, a 12-hour incubation for some bad street food makes sense, but 3 weeks for a parasite?
Right. It comes down to the life cycle of the organism itself.
Okay, give me an example.
Let's take Giardia intestinalis, which is the leading parasitic cause, alongside Cryptosporidium and Anthamoeba histolytica. The patient ingests the hardy cysts from contaminated water, right?
Yeah.
Well, those cysts actually have to survive the acidic environment of the stomach, pass into the alkaline duodenum, and then undergo excistation.
Wow, quite the journey.
It is. They hatch into trophozoites, which then multiply and attach to the intestinal mucosa using these little ventral sucking discs.
Ugh, descriptive.
I know, right? But that whole biological process, plus the time it takes to actually disrupt the brush border enough to cause malabsorption, it just takes weeks.
That makes total sense. The organism basically has to, like, set up camp and reproduce before you feel the physiological effects.
Exactly.
Let's look at the rapid onset bugs, though. The sources divide these into non-inflammatory and inflammatory pathways, which I find to be such a helpful way to conceptualize the symptoms.
It is a great framework. For non-inflammatory, you're looking at enterotoxigenic Escherichia coli, or ETEC, which leads the pack. It's responsible for about 30% of all cases.
Wow, 30%. And viral causes fit in here too, right?
Yeah, norovirus is the top viral cause, plus rotavirus. These non-inflammatory agents work by decreasing the absorptive abilities of the intestinal mucosa.
But without actually destroying the tissue.
Exactly. ETEC, for instance, produces enterotoxins that stimulate adenyl and guanylyl cyclase.
Ah, right, going back to basic sciences.
Right. This opens up chloride channels, pumping chloride into the gut lumen, and then water just follows osmotically.
It basically turns on cellular faucets.
That's a perfect way to put it. The mucosa remains totally intact, but you get copious watery diarrhea from decreased absorption.
Okay, whereas the inflammatory agents operate on a completely different mechanism. We're talking about Campylobacter, Jejuni, Shigella, and Salmonella.
Yes, the heavy hitters. These pathogens cause actual destruction of the intestinal mucosa.
So they're physically damaging the gut lining?
Yeah, they either release cytotoxins that kill the enterocytes, or they directly invade the mucosal tissue themselves. You still lose the absorptive surface area, which causes the diarrhea, but because there is active tissue necrosis.
And a massive immune response, I'm assuming?
Exactly. The clinical picture completely changes.
Which perfectly explains why we see hematochezia and tenesmus in those specific vignettes. There's actual bleeding and inflammation of the rectal vault.
Right.
It's a great distinction to hold on to for the exam. Watery secretory diarrhea from intact tissue versus bloody inflammatory diarrhea from destroyed tissue.
And tying that pathophysiology back to the patient history is critical, because the MCCQE loves to test on who is most vulnerable. They love modifiable risk factors.
Yeah, one that constantly pops up in question banks is proton pump inhibitor use. A patient on chronic heartburn medication is inherently at higher risk.
Biologically, stomach acid is a formidable primary defense mechanism.
It just melts everything.
Exactly. A highly acidic pH will denature the proteins of most ingested pathogens. But if a patient is on a PPI, their gastric pH is elevated.
So it drastically lowers the infectious dose required.
Exactly. A small amount of salmonella that would normally just be neutralized in the stomach can now easily survive the passage into the small intestine to cause disease.
That's such a good connection to make. And other risk factors follow a similar logic, don't they? Like recent antibiotic use.
Yeah, antibiotics strip away the normal gut flora. That removes the competitive inhibition that usually keeps those pathogenic bugs in check.
Right. And then you have populations naturally at risk for severe complications. The sources mention pregnant women, the extremes of age like kids under 4, and the elderly.
Also immunocompromised patients, and those with underlying chronic GI diseases. Plus, high-risk destinations like Sub-Saharan Africa, Latin America, the Middle East, and South Asia.
So, knowing all that, let's talk about the diagnostic workup, because this is where medical students frequently fall into traps.
Oh, labs are everywhere.
Right. You have a patient from a high-risk group, recently returned from South Asia, presenting with watery diarrhea. The instinct is to order a full laboratory workup.
Of course it is.
We are so trained to want data. I'd look at that vignette and immediately look for the option to order a stool culture, fecal leukocytes, lactoferrin, a PCR panel, maybe even an ultrasound if they have abdominal pain.
And that instinct will cost you points on the exam.
Ouch. Okay, why?
The overriding heuristic for the exam is innocent until proven guilty. In the vast majority of cases, traveler's diarrhea is self-limiting.
So when we're staring at a multiple choice question, our default stance should be innocent until proven guilty. We assume it's a self-limiting bug and avoid ordering a barrage of stool studies.
Exactly. Routine laboratory investigations are generally not required, and they won't change your initial management. Ordering unnecessary tests is a classic distractor answer.
Unless the question stem explicitly gives us a red flag, right? Like bloody stools or a high fever.
Right. High fever, hematochezia, severe tenesmus. Or if the symptoms drag on for weeks, then you might start checking for ova and parasites.
What about those multiplex PCR screens? I mean, they're becoming way more common in clinical practice.
They are, and the sources do acknowledge their existence and their ability to quickly identify multiple targets. But they explicitly note that these screens are expensive, they're not universally available, and again, they rarely alter the clinical management for an uncomplicated case.
So they are almost never the next best step on a board exam.
Pretty much never, unless the patient is severely immunocompromised or critically ill.
Good to know. I assume the same conservative approach applies to imaging as well.
Absolutely. Radiological studies, whether it's a CT scan or a KUB X-ray, are strictly reserved for patients where you suspect acute interabdominal pathology or, to rule out a perforation.
So if the patient appears highly toxic or has a rigid abdomen, then you image.
Yes, but for run-of-the-mill traveler's diarrhea, imaging is just incorrect.
All right, which brings us to the actual management. If we aren't testing, we still have to treat.
We do.
The absolute foundation, regardless of the pathogen, is fluid repletion. For mild cases, increasing water intake or using sports drinks is usually sufficient.
But you have to be specific in your counseling. The sources explicitly highlight the need to avoid milk and fruit juices.
Which I found so interesting. I mean, the fruit juice restriction makes sense from an osmotic perspective.
Yeah.
The high sugar content creates a hyperosmolar load in the gut lumen, which just draws more water out of the body and worsens the diarrhea.
Exactly. It just pulls fluid back in.
Well, why restrict milk? I wouldn't intuitively think of that.
It goes back to the mucosal damage we discussed earlier. The brush border of the intestine produces lactase, right?
Right.
Well, during an acute intestinal infection, even a mild one, those brush border enzymes are often temporarily sloughed off or depleted.
Oh, wow. So this causes a transient lactose intolerance.
Exactly. Giving the patient milk just adds an undigested sugar load to the gut, which exacerbates the bloating and diarrhea.
That makes perfect clinical sense. And if they are severely dehydrated, I assume you bypass all of that and just use specifically formulated oral rehydration salts.
Right. ORS is the gold standard there.
Okay, so fluids are replacing the volume loss, but patients always want the diarrhea to just stop, especially if they have to travel.
Of course they do.
Loperamide is the classic anti-motility agent, but I know there's a huge caveat here based on that inflammatory versus non-inflammatory distinction we talked about.
It's a massive caveat. For patients without signs of inflammatory diarrhea, meaning no high fever, no hematochezia, loperamide is excellent.
What's the dosing on that for the exam?
The adult dosing to remember is 4 milligrams initially, followed by 2 milligrams after each subsequent loose stool. And that maxes out at 16 milligrams per day.
Got it. But if they do have inflammatory symptoms, like Shigella actually invading the mucosa, anti-motility agents are incredibly dangerous.
Highly dangerous.
Using loperamide for an invasive mucosa-destroying bacteria is like locking the doors to your house while the burglars are still inside. You're just trapping the destruction.
That is a perfect way to visualize it. You are literally inhibiting peristalsis, which prevents the mechanical clearance of the pathogen.
So you trap the invasive bacteria and their cytotoxins in the bowel.
Yeah, which significantly increases the risk of systemic toxicity and even toxic megacolon. It's an absolute contraindication.
Good to underline that for the exam. Let's shift gears to prevention then. Bismuth subsalicylate is frequently discussed for prophylaxis.
It is, and it's quite effective. Taking 2 tabs 4 times a day can reduce the incidence of traveler's diarrhea by almost 50%.
That's pretty significant.
It really is.
Yeah.
It has both antimicrobial properties and anti-secretory effects.
Yeah.
However, there's a hard stop you need to recognize for the exam.
What's that?
It must be avoided in children and pregnant women due to the risk of salicylate toxicity.
Ah, right, salicylates. But I can totally see a clinical vignette where a patient going on a 3-month backpacking trip practically begs you for a daily preventative antibiotic prescription.
Oh, it happens all the time in practice.
As future physicians, we have to be the bad guys and select counsel against prophylaxis, right? The sources make it clear that long-term antibiotic prophylaxis does more harm than good.
You do. You have to stand your ground. Routine antibiotic prophylaxis is heavily discouraged.
Because it just ruins their microbiome.
Yeah, overprescribing these medications fundamentally alters the patient's microbiome, making them susceptible to C. diff, and it contributes massively to global antimicrobial resistance.
But there's always an exception in medicine, isn't there?
Always. The exception here is, for short, extremely high-stakes travel. The classic example is a diplomat, or maybe an athlete traveling to a high-risk area for a 2-day event where being sidelined by GI distress is just completely unacceptable.
Okay, in those rare cases, what do we give?
Rifaximin is commonly used because it stays within the gut lumen with minimal systemic absorption.
All right, what if prevention fails? The patient is highly symptomatic, and the illness is severe enough to warrant empiric antibiotic treatment. Traditionally, fluoroquinolones like ciprofloxacin were the automatic go-to.
They were, but this is exactly where the MCCQE will test your current epidemiological knowledge.
Yeah.
You have to be aware of what we call the Asia trap.
Yes, let's unpack the Asia trap because I've seen this concept repeated across multiple practice banks.
It's a big one. There are major concerns with fluoroquinolone resistance now, particularly driven by DNA gyrase mutations in Campylobacter species.
And these are prevalent where?
They are highly prevalent in South and Southeast Asia. So if the vignette describes a patient traveling to places like Thailand, India, or Vietnam, fluoroquinolones are definitively the wrong answer.
I remember from my infectious disease rotations that macrolides are usually the pivot here.
Yes, they are.
Are we looking at a standard Z-Pak dosing for these travelers, or does the exam want something more specific?
Azithromycin is indeed the preferred antibiotic for travelers to Asia. The standard regimen is 500 milligrams daily for 3 days. However, the sources also note that a single, larger dose of 1,000 milligrams can be highly effective.
Oh, that's convenient.
It is. And crucially, azithromycin is also your empiric drug of choice for pregnant travelers and pediatric patients, regardless of their destination.
Because of the safety profile.
Exactly.
So, just to recap for everyone taking notes, travel to Asia equals azithromycin. Pregnancy equals azithromycin. Pediatrics equals azithromycin.
Perfectly summarized. Recognizing that geographical resistance pattern requires the kind of clinical synthesis the exam really rewards.
All right, as we bring this clinical picture to a close, it's reassuring to know that the prognosis for travelers' diarrhea is overwhelmingly excellent.
It really is. The vast majority of these patients are managed completely as outpatients with hydration and supportive care.
So admission is quite rare. What's the specific threshold for actually sending them to the inpatient ward?
Admission is strictly reserved for severe dehydration causing hemodynamic instability.
Like, what specifically are we looking for in a vignette?
On an exam, you are looking for orthostatic hypotension. If they stand up and their blood pressure bottoms out, or if they have intractable vomiting that completely prevents oral rehydration.
Then they require IV fluids and inpatient monitoring.
Exactly. And the elderly and infants are obviously the most vulnerable to reaching this state.
Makes sense. So for the vast majority, it's an acute, self-resolving illness. You suffer for a few days, you stay hydrated, and it passes.
Right.
But I want to leave you, the listener, with a really fascinating piece of data from the StatPearls literature to sort of mull over.
Oh, yeah, this is a great point.
We tend to view this as a purely transient event, right? But there is a surprisingly strong correlation between this infection and the subsequent development of post-infectious irritable bowel syndrome.
It is a remarkable long-term consequence of what we otherwise just consider a benign infection.
Some studies suggest there is up to a 50% incidence of patients developing IBS after a bout of traveler's diarrhea.
Wait, half of these patients.
Up to 50%, yeah. It just invites you to consider how an acute inflammatory cascade can completely rewire the enteric nervous system.
That is wild.
The infection clears, the bacteria are gone, but the gut's motility and microbiome are fundamentally altered long after the traveler has returned home.
It really highlights the complexity of the gut microbiome and the enduring echoes of mucosal inflammation. It definitely changes the way you view the pathophysiology of something as common as E-tech.
It really does. Well, that brings us to the end of today's review. We hope this breakdown helps you navigate the strict diagnostic criteria, differentiate the mechanisms of high-yield bugs, avoid the unnecessary testing traps, and confidently maneuver through the pharmacological nuances of traveler's diarrhea.
Keep applying that underlying pathophysiology to the vignettes. Trust the incubation timelines, and always remember the Asia trap when selecting your antibiotics.
Thank you for joining us on this deep dive. Best of luck with your MCCQE exam preparation, and we will catch you next time.